Are you getting mine?
Yes, sir.
Okay. You're getting the screen?
Yes, we are
Yes,
getting.
sir. We are getting.
Yes, fine. Now, thanks a lot for giving the opportunity once again. So, my topic for today is surgical anatomy, which is relevant to cochlear implantation surgery. So, before I give my talk, just to answer a question which was raised yesterday by Dr. Deepak Dalmia, to show the Brackmann suction. This is the Brackmann suction, okay? So, the importance is that it has got integrated irrigation and suction channel. So one has to remember that this suction cannula is a little bit longer as compared to the irrigation cannula. So the irrigation is through this. This is connected to a drip set, and this is the suction. Okay, and this is the thumb point for blocking it. Okay, got it? Now,
Yes, sir. Yes.
just a minute. I got stuck. So let us start today's topic, that is surgical anatomy for cochlear implantation. So the first thing is that we'll go by layer and area by area. So the main interest area is nothing but the post-auricular region or post-oral region. So that is nothing but a part of a scalp. So what are the layers of the scalp? As we all know from our anatomy days in the first year of our MBBS, the scalp has got 5 layers. So S stands for skin, which has got appendages like the hair follicles. C stands for connective tissue. A stands for aponeurosis, that is nothing but galea aponeurotica, where the muscular layer is there. L stands for loose areolar tissue, and P stands for pericranium, or you can also refer to as periosteum. So let's go one by one. The skin has got hair or appendages. The connective tissue has got both the neurovascular supply, that means nerves, and also the blood vessels, that means arteries and veins. The galea aponeurosis contains the muscle layer. So from the front it would be the occipital belly, and from the back it would be the from the front it would be a frontalis muscle, and from the back it will be a occipitalis muscle. So occipitofrontalis muscle will be there, connected by a galea aponeurosis in between. And the next layer, or the fourth layer, is the loose areolar tissue, where you have something called as a emissary veins, which Manu was saying when he explained about the mastoid emissary veins during his last presentation. The last layer towards the skull bone is nothing but the pericranium or periosteum, which is very much deeply attached to the bone, more so attached very strongly near the suture lines. Now, let's know about the neural supply and the vascular supply of the scalp. We are interested in this region. This is anterior, this is posterior, this is the left, and this is the right. So if one has to do a implantation procedure on one side or either side, this is the area of interest. So this area is supplied by greater occipital and the lesser occipital. And the blood supply is from the anterior, it is nothing but the superficial temporal artery, which is the terminal branch of external carotid system. The post-auricular artery, which is also one of the branches of external carotid system, and occipital is once again the branch of external carotid system. So the main area which we are interested in is richly supplied by external carotid system. So this is the area of interest. Okay. Now, here, once again, we see the external carotid system here. This is the superficial temporal artery. And this is the area which is being supplied by the superficial temporal artery. And this yellow colored structure which is drawn here is nothing but the post-auricular artery. So post means posterior, Posterior to the auricle is postauricular, which is a branch of external carotid system. And this is the one in the green is nothing but the occipital artery. So any flaps which are to be designed to cover the receiver stimulator of the cochlear implant system or implant has to be designed in such a way you should not compromise on any vascular supply, or the flap should be very well receiving the blood from these vessels. So this is the idea of designing a flap based on the vascular supply. So the incisions which are designed for cochlear implantation are based on this arterial supply. Now, we were already saying that this is the frontalis belly and this is the occipitalis belly, and these are connected by something called as galea aponeurotica. Okay, this is the scalp here. Okay, and this is the fan-shaped muscle, which is nothing but the temporalis muscle, and we are going to harvest the temporalis fascia muscle over this in a tympanomastoid surgery. So this is the very well-known muscle, which is nothing but the temporalis muscle, which occupies the lateral aspect of the scalp. If you remove this muscle layer and these muscle layers, you are going to see something like this. That means you are exposing the skull bone. So once again, reviewing the anatomy here, this is the ear canal, the external auditory canal bone. This is the tympanic portion of the petrous temporal bone. This is the mastoid bone and the mastoid tip here. This is the cribriform area. This is the zygomatic root. This is the zygomatic root. And this is the temporal bone, and this is the squamous part of the temporal bone. This is attached to the sphenoid bone anteriorly. Superiorly, it is attached to the parietal bone here, and posteriorly, it is attached to the occipital bone here. So here, we are also showing some suture lines here. This is nothing but the temporoparietal suture line. This is the temporoparietal suture line. This is the suture line between the temporal part or the mastoid portion and the occipital portion. This is nothing but your lambdoid suture. This is nothing but your coronal suture. What exactly is this region is called as pterion, P-T-E-R-I-O-N. Pterion is a junction of suture lines of the skull where the frontal bone, parietal bone, the sphenoid bone and the squamous part of the temporal bone meet. This is called as a pterion. We are not interested in this region, but we are interested in one more region called as Asterion. Asterion is the point where the lambdoid suture meets the parieto-temporal suture line here. So why are we interested in this area is this is the area where you make a well or bed for cochlear implantation receiver stimulator. So this is the area of interest to make a bed for cochlear implant receiver stimulator. So roughly it would be somewhere around 45-degree angulation to a line drawn from the lateral canthus of the eye towards the upper part of the external auditory canal. This is called as a Frankfurt's plane. If you draw a Frankfurt's plane like that and you draw at an angulation of 45 degrees, at the level of the asterion, you need to make a bed. So this is the relevant anatomy on the skull bone. This is the area which I was saying is nothing but the asterion. Okay, this is nothing but a junction point of your lambdoid suture and the parieto-temporal suture line. Okay. Now, one more area which we are talking about, the asterion. We'll just go back to this slide. So if at all we make a bed for cochlear implant receiver stimulator here, what happens to these suture lines? Does it interfere with any skull growth is a big question. In fact, this, even if there is a bed which is made in the or on the suture lines, this is not going to affect the skull growth in any way in a pediatric age. group or a pediatric population. That is the take-home message here. Now, a word about the skull thickness here. We do most of the cochlear implantation procedures in a pediatric age group where the skull size is less, the skull thickness is less, and it is very, very vascular. The Haversian canal systems are very dense in a pediatric population as compared to the adult population. The marrow bone is more in the pediatric population as compared to the adult bone. So that is the reason why, in case if you have to drill a scalp bone or the skull or the mastoid system, if you see a lot of marrow bone that was described by Dr. Manu in his earlier presentation of the imaging, where he said that one has to see whether it is well pneumatized or a diploic bone or a marrow bone there. If one has encountered or one has seen a lot of marrow bone on the imaging, one has to go for a drilling starting with a diamond burr instead of going with a cutting burr. So now a word about the skull thickness here. So as the age grows, the skull thickness also improves. Initially in the newborn, it may be 1 to 2 millimeters, which can go up to 6 millimeters in the 3-year age group. But we are not interested in this area. We don't expect a skull thickness of 6 millimeters in a 3-year age group over the lateral part of the skull. We are interested in this region and not this region. This is the vertex. So at the vertex, the skull thickness may be very thick. The thickness may be more, but we are not interested in this region, but we are interested in this region, which corresponds to somewhere around 3 to 4 millimeters. So if you are implanting an infant that is less than 1 year of age, the expected skull thickness may be somewhere around 1 to 2 or at the max 2.5 to 3 millimeters. So once you have to go for an implantation in a very young age group, you have to check the skull thickness on imaging and prepare accordingly. The bed which is made for a cochlear implantation receiver stimulator may not be made more than 2 or 3 millimeters, and it also depends upon the profile of the cochlear implantation receiver stimulation. Now, if you have to do a cochlear implantation in a very young age group and the skull thickness is very, very less as compared to the implant profile. Suppose you take a cochlear implant or you select a cochlear implantation receiver stimulator whose profile, that is thickness of the cochlear implant receiver stimulator, if it is very thick, somewhere say around 6 millimeters or 4 to 5 millimeters, and you have to do it in a pediatric age group whose skull thickness is somewhere around 1 to 2 millimeters, is not going to fit. That means you have to expose the dura and you have to depress the dura to keep the cochlear implant receiver stimulator snugly fit in the bed. So it is not going to work, or you are going to take a chance where you may injure the dural vessels or encounter any bleeding or CSF leak. To avoid making a big well or a deeper well, you can also resort to something called as a subperiosteal technique or T-pocket technique. This is described by Dr. Thomas J. Balcony from USA. So here what we do is, instead of making a receiver stimulator bed, we are going to make a pocket underneath the musculoperiosteal flap, and we are going to just push this receiver stimulator package into that tight pocket so that it stays over there. So this may be taken up in a pediatric age group where there may be a complication due to exposure of the dura. Now, if one has to go for a pocket or if one has to go for a bed making, where to make it? So you can't make it here, you can't make it here, you can't make it here. There is a space where one has to go for a receiver stimulator bed. So that region is called as cochlear implant peninsula. Peninsula is nothing but an area which is almost triangular. Okay, so this triangular area is bounded by anteriorly, it would be a temporoparietal suture line, this one, and posteriorly it is temporo-occipital suture line. So in between these two, or you can also call it as a lambdoid suture here. So anteriorly it would be this suture line, the temporoparietal one, and posteriorly it would be a lambdoid suture, or more importantly you can call it as a temporo-occipital suture line. So if you make a very tight pocket in the subperiosteal plane, this can go strictly here, which can be in a tight pocket because of the tight attachment of this layer at the suture lines. So if one opens this layer at the suture line, there is no point in making a pocket here. So one has to make a tight pocket in between these two suture lines. So one has to elevate the subperiosteal plane only in between these two suture lines. So that is the idea of making a T-pocket technique. Suppose one has to go for a bed, you can make it in the Asterion or even in this region as per the Scalp. Okay. Now, once you have designed a implant bed in one region of your interest, the next thing is to go for a mastoid cortex exposure. To expose the mastoid cortex, one need to elevate the musculoperiosteal flap. So once you remove this musculoperiosteal flap or elevate it, then only you can expose the mastoid cortex. Now, there are a lot number of flap designs. There are nearly 4 to 5 flap designs that may be useful or that can be used in a case of cochlear implantation. The most common ones which we use in a tympanomastoid surgery is nothing but the anteriorly based flap, musculoperiosteal flap, which is called as Palva's flap. That means you design in such a way, you make a horizontal cut superiorly and inferiorly and join this by a vertical cut here. So this blood vascular strip is from here. So it is a anteriorly based vascular supply. So the anteriorly based musculoperiosteal flap is called as Palva's flap. Suppose you design a flap in this way, giving a cut vertical here, and a inferior cut here, and you raise the flap like this. That is a superiorly based flap. That flap has got blood supply from superior portion. This is a superiorly based flap that is called as Hong Kong's flap. Suppose you design a flap like this, which is deriving its blood supply from the inferior portion, that is a inferiorly based flap, that is called as Japanese flap. Suppose you raise a flap based on the arterial supply which comes from the posterior, that is a posteriorly based flap. In fact, we don't go for a strictly posteriorly based flap. Instead, we give a incision in the horizontal incision at the level of the inferior temporal line here, and one line here just posterior to the bony external notary canal here, and we raise the flap like this. That is a posterior inferiorly based flap, that is called as Muirman's flap. So the flap design can be of use according to the cochlear implant receiver stimulator profile, and it can also be the choice of the surgeon or any given situation. We go with a posterior inferiorly based flap, which is called as a Muirman's flap. That is a posterior inferiorly based supply. So the idea of elevating a superiorly based flap is that the implant profile is fully covered. The idea of taking a anteriorly based flap is it is most commonly used. The idea of taking a posterior inferiorly based flap is you can design or you can extend the posterior inferiorly based flap as per your requirement to reach the area of receiver stimulator bed, and also you can go much more anteriorly and do your work without elevating onto the tympanomeatal flap or without entering the external artery canal here. That is the idea of elevating a posterior inferiorly based Neurman's flap. Now, once you have exposed the mastoid cortex, depending upon the choice of your flap, you are going to expose the mastoid cortex. So once the mastoid cortex is exposed, what is the region which we are interested in is called as Mesotympanum triangle. The Mesotympanum triangle, this is the imaginary triangle over the mastoid cortex defined by a supramastoid crest superiorly, a line drawn along the external artery canal, and this line is not that well defined, but it joins the first to the second. It is said that it can be perpendicular to one line and join the other, but these two are a must to know. One is the one drawn along the supramastoid crest and the other a tangential along the external artery canal boning. So if these two are defined, this can be either anterior or posterior depending upon the level of the sinus plate. Now, once you expose the mastoid cortex, this is called as cribriform area. Cribriform means sieve-like. That means the aeration in the mastoid air cell system exposes to the outside, and also these sieves are made by infantile vascular system. Now, if one has to do a mastoidectomy, what mastoidectomy one has to do? One has to do a cortical mastoidectomy. A difference between a standard mastoidectomy that is done for a cochlear implantation is differed from the cortical mastoidectomy in a few aspects that will let you know in a few minutes. Now, if one has to drill a mastoid cavity, or if one has to do a mastoidectomy per se, a cortical mastoidectomy or a standard mastoidectomy, you are going to know how deep you will be getting the mastoid antrum, which is the most common, biggest and the antral, biggest mastoid air cell. That is called as mastoid antrum, which will lead to the editor's ad antrum. It is the entry point between the mastoid air cell system and the epitympanum. So this mastoid antrum is the most constant and it's almost always present, and it's the one of the biggest mastoid air cell system. As we all know, this mastoid antrum measured from the cortex, that's the mastoid cortex laterally, is approximately 12 to 15 millimeters deeper. But this is in adults. Suppose one has to do a mastoidectomy in a newborn. What would be the mastoid antrum depth? We really don't know. Now, a simple this estimation of the mastoid air cell system growth pattern is given in a few journal. Here, as the age grows from the newborn to the pubertal age, this mastoid air cell system is going to grow like that. And if you see a growth pattern here, initially this is around the 2 years of age, the growth system is very, very high. This is the mastoid air cell growth pattern is very high here. And it has increased over a period of 6 years by the age of 6 years. And it tends to get slowed down over a period of years till the puberty, and at this level it be constant. So this is not about the depth of the mastoid antrum. This is about the mastoid air cell system growth. Now, if you have to do a pediatric mastoidectomy, how to calculate? I'll tell you a very simple definition or a pattern how you can go ahead with. Now, the depth of the mastoid antrum from the cortex in a 2-year-old child is approximately 3 millimeters. By the age of 2 years, the child is very active. So he's going to do a lot of things, and his muscle, which is nothing but a sternocleidomastoid muscle, is put into action at its maximum. And by the pull of the sternocleidomastoid, the mastoid tip is dragged down. So the mastoid air cell system is going to be pulled by the mastoid tip by the sternocleidomastoid muscle. This is how the mastoid air cell system grows. Suppose there is no pull from the sternocleidomastoid, there is not going to be any growth, or there is going to be a very less growth as compared to the ones which has got an active sternocleidomastoid action. So as the child grows in age, as the pull of the sternocleidomastoid is stronger, the mastoid air cell system is going to grow, and the depth of the mastoid antrum gets deepened. How much it gets deepened? It's approximately 1 millimeter per year. So in a 4-year-old child, the mastoid antrum depth from the cortex would be, for the 2 years it is 3 millimeters, the 3rd year it is +1, 4 millimeters, and the 4th year it will be +1, that is 3 + 1 + 1, it is approximately 5 millimeters in a 4-year-old child. If it is 8 years, you can calculate 3 + 1 millimeter per every year. And if you calculate the same way, by the age of 12 or 13 years, the mastoid antrum depth would almost be reaching the adult life. And this corresponds to the mastoid antral depth given in adults. So this is the best way to assess the depth of the mastoid antrum from the cortex in a pediatric age group. Suppose if you are operating a 4-year-old child, your estimated depth of the mastoid antrum from the cortex would be 5 millimeters. So you are going to use a 4 millimeter burr. So you downsize the burr by approximately 1 millimeter and go ahead. Don't start with a 6 millimeter burr in a 4-year-old child. So this is the take home message here. Now, I was telling about this standard mastoidectomy. The standard mastoidectomy is nothing but like a cortical mastoidectomy. It is exenteration of the mastoid air cell systems. By definition, cortical mastoidectomy is exenteration of all the accessible mastoid air cell systems. So here we are not going to exenterate all the mastoid air cells here. We are going to exenterate only the mastoid air cells which we are interested in here. A small thing, what do you mean by exenteration? What do you mean by eradication? Eradication means you are opening up a mastoid air cell which is diseased. Exenteration means opening of the mastoid air cell system irrespective of its pathology. So a standard mastoidectomy differs from cortical mastoidectomy in that you are not going to open all the mastoid air cells here. Here we haven't gone to the zygomatic air cells. Here we did not go to the retrofacial air cells. We did not clear the tip cells here. Here we did not go with the sinodural angle, or we did not expose or delineate the sigmoid sinus plate and the tegmen mastoidium here. And also you see the mastoid cavity is not saucerized here. It is always undermined here. The idea of undermining these things here, the borders of the standard mastoidectomy are undermined in a way that when you keep a cochlear implant electrode loop here, it will come out if you saucerize this borders. If you undermine these things, this electrode loop, the cochlear implant electrode loop, will be held in the mastoid cavity, preventing its extrusion from the cochlea. Okay, that is the idea of doing a standard mastoidectomy, where the air cells are not all open and the borders here are undermined and not saucerized. Now, when do you call a standard mastoidectomy to be complete? When you talk about a cortical mastoidectomy, you have to open the mastoid antrum here. You have to delineate the ossicular chain, that is nothing but the incus here. You have to delineate the lateral semicircular canal, and you have to define the mastoid tip. So these are the boundaries of cortical mastoidectomy, medially and anteriorly and inferiorly. So superiorly, it is the tegmen mastoidium. Posteriorly, it would be the sigmoid sinus plate, and posterior superiorly will be the sinodural angle. This is all for cortical mastoidectomy. In a case of standard mastoidectomy, we are not going to define the Tegman mastoidium. We are not going to define the sinodural angle. We are not going to define the sigmoid sinus plate. We are more interested in antrum. We are more interested in this incus. We are more interested in lateral semicircular canal. We are most interested in thinning out the posterior canal wall. We are more interested in delineating and not exposing the facial nerve. So when you complete a standard mastoidectomy, you should be identifying the mastoid antrum, which is identified by something called as stalactites, which will lead to the mastoid editor-side antrum. And the component of this epitympanum is nothing but the malleus here and the incus body. We are not going to expose the malleus here anyway. We are going to expose the body along with the short process. This incus is housed in a space called as fossa incudus. Fossa means space, incudus means incus. The space where the incus lies is called as fossa incudus. So you have to expose the incus body along with the short process. You have to identify the dome of the lateral semicircular canal. You have to delineate the facial nerve, and you have to make the posterior canal wall thinner. Okay. Now, how to delineate a facial nerve? Where should one expect the facial nerve? A simple thing is draw a line. Draw a straight imaginary line starting from short process of the incus towards the digastric ridge. Suppose this would be the digastric ridge and this would be the short process of the incus. Draw a line like that. If you draw a line, the facial nerve almost always lies posterior to it. Almost always. This is not a dictum that it should always lie in 100% of the cases, but in more than 90% of the cases, the facial will lie posterior to a line joining between the short process of the incus and the digastric ridge here. So if you draw an imaginary line here from the short process of the incus towards the digastric ridge, the facial nerve lies almost always posterior to it. Now, the facial nerve in the superior portion is anteromedial, and as it comes downwards here in the lower portion, it will be posterior and lateral. So it would be anteromedial here, and as it comes down, it would be turning posterolaterally from anteromedial to the posterolateral. So this would be the area of interest, which is called as a posterior tympanotomy site. Now, this is just a temporal bone where a facial nerve is delineated fully. If you draw a line from the short process of the incus here and the digastric ridge, if you draw a line like that, the facial is almost always posterior to it. Now, where to do a posterior tympanotomy, we'll let you know. Once we know the facial nerve boundaries, we will be very happy to go ahead and do any procedure in a mastoid or a petrous temporal bone. The petrous temporal bone beauty, the dissection and the surgery is all about the landmarks and the identification of the facial nerve. Now I'll tell you a very few points to easily identify the facial nerve in any given situation. Now I'll tell you one by one. In the mastoid bone here, in the mastoid, we are not going into the external auditory canal and the middle ear here. We are talking only in the mastoid one, and then we'll go to the middle ear. So this is the canal wall of mastoidectomy here. Now, the facial nerve will be lying. These are all landmarks which I am saying. Lies posterior to a line joining from the short process of the incus to the digastric. Number one. Number two, the facial nerve lies in the floor of the editor-side antrum. Number two. Number three, the facial nerve lies medial to the incus. Number four, the facial nerve lies anteromedial to the lateral semicircular canal. Number five, the mastoid portion of the facial nerve is approximately 2 millimeters anterior to the ampulla of the posterior semicircular canal. The next number, the facial nerve will be always lying medial to the digastric tissue. The facial nerve will never ever come above the or lateral to the level of the digastric ridge. Now we go into the middle ear. Yeah. Now the facial nerve is this one. So this is the mastoid segment of the facial nerve, and this is the tympanic segment. This is the second genu, the junction between the tympanic segment and the mastoid segment. This second genu portion is posterolateral to the stapes of the stapes footplate or the oval window area. That is one more landmark. This tympanic segment runs horizontally like this and ends at just anterior and above to the one common structure which is well preserved in any given situation almost. This is nothing but the process cochleariformis. So one more landmark in the middle ear is that the facial nerve runs above, the tympanic segment runs above and takes a turn into the labyrinthine segment at the level of the first genu here, which is approximately 1 millimeter anterior and superior to the processus cochleariformis. And it takes a 70-degree turn here, and this is the labyrinthine segment of the facial nerve. Once again, this labyrinthine segment of the facial nerve lies posterolateral to the posterior half of the cochlea. That is one more landmark. Now, the tympanic segment of the facial nerve, if there is a line drawn here, if you are able to see a faint line here, this is nothing but the Jacobson's nerve which runs over the promontory. So the facial nerve tympanic segment lies always posterior to the Jacobson's line, Jacobson's nerve demarcation here. Okay. Now, this facial nerve is posterolateral to the oval window and anteromedial to the lateral semicircular canal. The same thing. The facial nerve runs posterior to the pyramidea. Okay. These are the landmarks. Okay. The lot many landmarks, what I have described is only relevant to the tympanomastoid surgery. Any given situation, you can find the facial nerve at ease depending upon these landmarks. The few things which I missed out are the mastoid segment of the facial nerve is posterior to the tympanic annulus, at least in the lowermost portion here. And also the tympanic segment and the mastoid segment, the facial nerve is covered by a sheath in which runs the vasa nervosa, that is nothing but the blood vessel which is supplying the nerve. So the horizontally running and the vertically running, the only horizontally running blood vessel in the middle ear is nothing but over the facial nerve. The vertical blood vessel which is running in the mastoid compartment or the mastoid air cell system is nothing but over the facial nerve. This can also be a landmark which can be served in a tympanomastoid surgery. The one landmarks which are shown in pink are in the CP angle here. The one which is shown in the green is the landmark for facial nerve in the internal auditory canal. This is in the labyrinthine segment. The one which is shown in blue is related to tympanomastoid surgery or the tympanomastoid area. And the one which is shown in light green here is nothing but the landmarks for the facial nerve in a parotid region. So you have nearly 25 landmarks for the facial nerve. So depending upon these landmarks, one should be able to identify, or one can try to identify a facial nerve in any given situation. Now we know that the landmark for the facial nerve here, and we can expect the facial nerve here. So where to do a posterior tympanotomy? The posterior tympanotomy by definition means, tympanotomy means opening of tympanum. Tympanum means middle ear. If you open the middle ear from posterior, that means you go and attack the middle ear from the posterior, that is the mastoid portion, that is called as posterior tympanotomy. if you open the tympanic cavity from the anterior, that is from the external artery canal, raising the tympanum at a flap, that is called as anterior tympanotomy. So here we are interested in posterior tympanotomy. That means we are opening into the middle ear via posterior root or the mastoid root, that is called as posterior tympanotomy. Now we have something called as boundaries for posterior tympanotomy. What are they? Are superiorly incus bar, inferiorly the facial and the chorda junction here, that is called as chordofacial angle. Posteriorly and medially is the facial nerve. Anteriorly and laterally is nothing but the chorda tympani. I repeat, the borders or boundaries of posterior tympanotomy are incus bar superiorly, inferiorly the chordofacial angle, posteromedially the facial nerve, anterolaterally the chorda tympani. So there is a space through this boundaries you can attack into the middle ear via the mastoid root. The incus buttress or incus bar or incus bridge is a piece of bone here between the short process of the incus and the posterior tympanotomy air cells. This posterior tympanotomy air cells is nothing but the facial recess cells. The facial recess cells may be pneumatized or without any cells. Usually there will be a small cell which is constant, that is called as sentinel cell, that will lead into the posterior tympanotomy site or facial recess site. And once you open it very well, taking care that you don't injure the facial nerve and the chorda tympani or the tympanic annulus anteriorly, one can get into the middle ear here. Once you get a glimpse of middle ear, posterior part of the middle ear, you should be able to see the incudostapedial joint, the stapedius tendon, the stapes head, the stapedius tendon attached to this pyramidal eminence here. You may be able to see the round window, you may not be able to see. You should be able to see the medial wall of the middle ear, which is nothing but the basal turn of the cochlea, which is called as promontory. So these are the structures which can be or which should be visualized on posterior tympanotomy. Now, if suppose the posterior tympanotomy, this is in the left bone, if you do a posterior tympanotomy and you want to extend it either superiorly or inferiorly, in cases of cochlear superior rotation or inferior rotation, you can still extend the posterior tympanotomy. We'll just go back to the previous slide. This is the posterior tympanotomy conventional. So this is the extension of the posterior tympanotomy. That means this is extended superiorly or it can be extended inferiorly. If suppose you extend superiorly, you just take out this piece of bone here. That was nothing but the incus buttress or bridge or bar. If you remove the incus buttress, that means you are extending the posterior tympanotomy superiorly. If you have to extend the posterior tympanotomy inferiorly, you can't sacrifice the facial nerve. That is more important. So you can sacrifice the chorda tympani instead. So this will be the chordofacial angle. This is the facial and this is the chorda tympani. So you cut the chorda tympani here and extend it like that. So the posterior tympanotomy can be extended superiorly at the expense of the incus buttress. It can be extended inferiorly at the expense of the chorda tympani. It can be extended even anteriorly. Anteriorly there is a anterolaterally there is a chorda tympani. We can sacrifice it. We can also sacrifice the posterior canal wall, thereby extending anteriorly. But you should not think of anything like a extension of the posterior tympanotomy posteriorly. Posteriorly and medially we have nothing but the facial nerve. We cannot sacrifice the facial nerve just for the sake of opening up the middle ear. So how to extend anteriorly? We have shown the extension anteriorly can be done by something called as Bruce Gans technique, which is advocated, and again it is popularized by one person by name Craig Brackmann. This is also called as a Brackmann's technique, where the extension of the posterior tympanotomy is anteriorly made by giving a vertical cut here and here. So after you extend the posterior tympanotomy superiorly and inferiorly, you give a vertical cut in the superior portion and the inferior portion of the bony posterior canal wall. You are not going to injure the skin here. You are not going to do anything or cut anything in the canal wall skin. You are going to give cuts only in the bony posterior meatal wall. If you make cuts here and extend the posterior tympanotomy, you can just push like that, this way. Once you push this way, you are going to expose the middle ear from posterior way much anteriorly. This is called as extended posterior tympanotomy anterior, which is by Bruce Gant's technique or Brackmann's technique. This was the question asked in first lecture. So this is the explanation for that. Now, a short note about something called as retrotympanum. The posterior most portion of the middle ear is called as retrotympanum. Retro means posterior, tympanum means middle ear. It has got 4 spaces. Not just, we know only one thing, that's a facial nerve here, which is just posterior to the pyramidal eminence here. So anything lateral to the facial nerve is nothing but the facial recess. Anything medial to the facial nerve is nothing but the sinus tympani. But it is not only sinus tympani and the facial recess. It is 2 more structures which are there. So there are totally 4 structures. The one which is, if this is the facial nerve, anteromedially we have posterior tympanic sinus. This is called as a PTS, which is in the uppermost portion, and a more big portion inferiorly is the sinus tympani. Both are medial to the facial nerve. Both are medial to the facial nerve. Superiorly it is the posterior tympanic sinus, and inferiorly it is the sinus tympani. Once you go lateral to the facial nerve, you are going to expect nothing but the facial recess. It is not correct to call the facial recess as facial recess. It's not a recess but a sinus. It's better to call always it as a facial sinus, which is superior most portion. And again, inferiorly, you are going to encounter one more space called as lateral tympanic space. Once again, I repeat, retrotympanum has got 4 spaces or sinuses. Medial to the facial nerve would be the posterior tympanic sinus in the superior portion and the sinus tympani in the inferior portion. Lateral to the facial nerve will be facial sinus superiorly and lateral tympanic sinus inferiorly. This is one of the Viva questions in the MS exam. Now, a short note about the middle ear medial wall. The middle ear medial wall is formed by promontory, which is nothing but an elevation created by the basal turn of the cochlea. This is nothing but the promontory, which is formed by the basal turn of the cochlea. So the basal turn of the cochlea can be entered through a window called as round window. Round window serves an entry point, or like it acts like a door from entering into the scala tympani of the basal turn. Suppose one opens this round window and goes and peeps inside, you will be able to see the scala tympani of the basal turn of the cochlea. Okay, so this is the relevant anatomy. So what is the relation of the stapes here and the oval window to the round window? So the distance between the oval window and the round window can be somewhere around 2 millimeters here. So the distance between the oval window and the round window can be 2 millimeters, and here it can be up to 4 millimeters, where you can encounter the hypotympanic air cell system. There can be an accidental entry into the hypotympanic air cell system via the cochlear implant electrode. So one has to be careful while opening a round window, and identification of the round window is very important in a cochlear implantation surgery. If suppose the round window here is sclerosed or hidden, one should expect, or one should search for a round window inferior to the oval window approximately by 1 to 2 millimeters. So the round window is always inferior approximately by 2 millimeters to the oval window, number 1. Number two, the round window will be always posterior and inferior to the whole window. You should not touch straight like that. You should touch like this. The round window is posterior and inferior to the whole window. So you should search in this way, not this way. Okay. Now, the round window visualization is also important. So if suppose one does a posterior tympanotomy and looks for the round window, there is a classification given whether you are able to see the round window and the membrane or not. If the round window membrane is visible more than by 50%, then it is called as a grade 1. If suppose the round window and the membrane is visualized up to only 50%, that is 25 to 50%, that is called as a grade 2. If it is visualized less than 25%, that is called as a grade 3. If the round window is not visualized, then it is called as grade 4. So if one has encountered a grade 1 or grade 2, that is a favorable situation where one can go ahead with a electrode insertion via the round window route. If someone encounters a grade 3 round window membrane accessibility or grade 4 round window membrane accessibility, this will be a difficult situation to go ahead and do a cochlear implant electrode insertion via the round window. In such a situation, one may resort to another procedure called as cochleostomy. Ostomy means opening. Cochleostomy means opening of the cochlea. That means opening the bone of the cochlea and entering the cochlea. That is called as conventional or bony cochleostomy. One has to resort, or one may resort to a conventional cochleostomy or a bony cochleostomy if the situation given is either grade 3 or grade 4. There are also a few situations where we cannot go with a round window insertion and you don't want to do a bony cochleostomy. There is one more situation called as extended round window that we'll explain you in a few slides. Now, once you do a posterior tympanotomy and you are able to see the full face here, more than 50% of the round window membrane is visualized, it's almost 60 to 70%. That is called as grade 1 classification. Okay, the round window membrane, if it is visualized 25 to 50%, that is called as grade 2. This is given by St. Thomas Hospital in London. So there's also one paper by Naresh Panda from PGI Chandigarh. They have just described the same thing. This is actually given by St. Thomas Hospital from London. Okay, the grade 3 situation is where the round window membrane is not that great, that is less than 25%. Here we are not at all seeing any round window membrane. So this is a grade 4 situation. In this sort of a situation, one has to resort to a bony cochleostomy in most of the cases. Here, one can try an extended round window, or one can go ahead with a Brackmann's technique and do a cochlear implantation electrode via either extended round window technique or a round window technique. Now, if one has to go through a round window, which is the recommended these days, the round window is not a simple structure that is visualized very clearly. That is, in fact, covered by a bony ledge like that in the superior and the posterior portion called as round window niche. The round window niche is nothing but a bony ledge in the superior and the posterior portion. Posterior superior bony ledge covering or hiding the round window membrane is called as round window niche. In the posterior superior portion, it is called as operculum. Once you remove this bone by drilling, usually using a 1 millimeter diamond burr, you can expose the round window membrane. So once you identify the round window membrane in its 360 degrees, then you can open the round window membrane and gain access like this. So this is the round window membrane fully exposed and open. This is the one where the partial drill out of the round window niche is done. Now, a point, the round window niche can be quite thick in a few individuals. That can be identified before implantation surgery on imaging. one can anticipate whether the round window membrane is easily accessible or it is covered by a round window niche, and to what extent. Usually, the round window membrane is at a depth of 1 millimeters from the round window niche. So that is the reason why we go with a 1 millimeter diamond. Once you drill out the round window niche with a 1 millimeter diamond and you are able to expose the round window membrane, the 360-degree full face of the round window membrane exposure can be again checked with the use of a 1 millimeter diamond. Suppose you keep the 1 millimeter diamond over the round window membrane, it will cover the full membrane. That is how you identify whether the round window membrane is fully exposed or not. Number two, the round window membrane will not be round as we think. It will be at an angle that will explain you. It will be like a Pringle shape and it will be dark. It will be dark. Now, the same thing here. This is the basal turn of the cochlea here. This is the scala here. This is the scala vestibuli. This is the scala tympani. This is the scala media. And this is the osseous spiral lamina, and laterally it would be the basilar membrane. This is the round window which gives access from the middle ear here to the basal turn of the cochlea, scala tympani. So this is the ledge of the bone which covers the round window membrane like that. If you remove this round window niche, then only you can expose the round window membrane. Here you are seeing the round window membrane in its 360 degrees. This is the full face of the round window membrane exposed. Now, a few words about the round window. The round window has been described by Antonio Scarpa. It's also called as Scarpa's window. It's also called as secondary tympanic membrane. It is having three layers, same as tympanic membrane. The outer one is the mucosal layer. The middle one is the encontral layer, and the third one is the periosteal layer. Sorry. Now, the round window is not really round. It can be ovoid or it can be a non-planar structure, something like a saddle. This is nothing but a potato chip or a Pringle here. Or it can be also like a horse saddle. Okay. So, in technical terms, this is called as hyperbolic paraboloid. This is a very confusing word. So the simple thing, if you have to describe the shape of the round window membrane, that would be like a saddle-like. This saddle-like structure of the round window is not like a straight line. It is like a saddle-like. It has got an anterior-inferior portion which is more anterior and medial. It has got a posterior portion which is posterior, superior and lateral. So if you imagine the round window membrane seen from the anterior region, it will be like a chair shape. It will be like a chair shape. Again, I repeat, the round window membrane is aligned more vertically in the lower portion or the anteromedial portion, and it is aligned more horizontally in the posterior and superior portion. It is a saddle-like structure. So we have a lot of variations of the round window membrane shape. There are nearly 32 varieties of round window membrane shapes described by Takahashi. This is from Francesco Attura. He has described 30 different varieties of round window membranes. Okay, whatever be the shape, one has to expose the round window membrane in its full face and then go ahead with the round window cochlear implant electrode insertion like this. Here we have inserted a cochlear electrode. This is by Cochlear company. The specific electrode is nothing but CI24REST. ST stands for straighter electrode. So this is inserted via the round window membrane. So these are called as stiffening rings. There will be 10 stiffening rings in case of CI24REST. So 5 will be outside, 5 will be inside. And the active electrodes will all be intracochlear. That means inside the cochlea. So this is a perfect insertion of the cochlear implant electrode via the round window. So once you get the X-ray done, this is how it looks. See, you should not get confused that this should be full round. For a given electrode, this is the best insertion depth angle. For a 24 REST electrode, this is the only thing we can expect is a classical J-shaped insertion. If you get a advanced bionics cochlear implant electrode, it will be something like this. If you go for a medial electrode, it will be some more two turns like this, which is called as complete cochlear coverage. Now, we always should try to go ahead and do a round window insertion in as many cases as possible. Suppose the round window accessibility is not that great and STH classification is somewhere around grade 3 or grade 1, but still one don't want to go ahead with a cochleostomy. One can go and extend this round window membrane inferiorly and anteriorly. I repeat, it is first inferior and then anterior. It is not anterior inferior, it is infero anterior. That means you go inferiorly and then go anteriorly. That is called as extended round window. Okay, so this is the extension of the round window and inferiorly and anteriorly. Suppose one has to go with a cochleostomy. This is the site for bony cochleostomy. It should be 1 or 1.25 millimeters inferior and anterior to the round window membrane. So there are 3 types of cochlear implant electrode insertions. This is round window technique, conventional cochleostomy technique, and the extended round window technique. If one has to classify, this round window is classical round window. The cochleostomy and the extended round window both come under cochleostomy only. Both come under cochleostomy as we are drilling. Okay, suppose one drills the cochlea, like in the case of a bony cochleostomy or extended round window, one can encounter a small ridge like this. This one, see, this is the middle ear here. This is the posterior semicircular canal. This is the cochlea with the scala tympani here. This is the scala vestibuli. This is the interscalar partition here. This is the round window membrane. This is the round window pseudo membrane. That means the mucosal layer of the middle ear can form a thin film covering the round window membrane and cheating us like a round window membrane. That is called as pseudo round window membrane. One has to just take off this and then identify the round window. I said the round window membrane will be dark, but the pseudo round window membrane or a false round window membrane, which is formed nothing by a mucosa of the middle ear, is not that dark, and one has to just clear off the mucosa before exposing the round window membrane. If suppose once again you see this one, this is the osseous spiral lamina here. The osseous spiral lamina is in continuity posterior superiorly with the round window membrane, and inferiorly and anteriorly there would be a bony ledge from the lateral wall of the cochlea near the round window. Just anteriorly, this is a bony ledge. This is called as crista fenestra. Again, this is called as a crista fenestra, is a bony ledge in the scala tympani of the basal turn of the cochlea, just at the anterior and inferior portion of the attachment of the round window membrane. Suppose one has to do a cochlear implant electrode insertion via the round window. If someone goes like this, he will be entering very, very straightforward into the scala tympani of the basal turn, which is the ideal situation and the desired situation. If suppose one tries to go like this and the electrode hits this crista fenestra, it tends to get deflected like this and will hit the osseous spiral lamina and will go into the other scala, that is nothing but scala vestibuli, which is not an ideal situation or which is not desired in a cochlear implantation. So if this crest is very prominent, you have to take out this crista to gain access easily into the scala tympani of the basal turn for your electrode to enter. So the more prominent the crista fenestra, the more difficult situation it would be to enter the basal turn of the cochlea via the round window. One has to drill this by an extended round window technique or resort to a bony cochleostomy. That is the idea. Suppose this is the round window side and this is the cochleostomy side and this is the extended round window. You are able to see a small structure here. Somebody is pointing here. This is nothing but the posterior semicircular canal. Okay, so this is the crista fenestra, which is nothing but a bony ledge which will be there in the antero-inferior. This is the anterior, this is posterior, this is superior, this is inferior. So this is antero-inferior where the round window membrane gets attached. So if this is very prominent, the electrode insertion will be deflected like that. That will go and hit the osseous spiral lamina and may fracture it entering the scala vestibuli. That is not desired. Now, the same thing which is explained by a better picture here. This is the round window opening here. And this is the basal turn of the cochlea. The basal turn is not straight like that. It is in fact like this. So the round window, if at all one has to gain access through this, if the crista is very prominent, it has to be drilled out and one has to go with a conventional cochleostomy or a extended round window. If you go through this, this is the round window insertion. If you extend here, that is called as extended round window. And if you resort to a cochleostomy here, that is called as a conventional cochleostomy. A more straighter electrode will go through like this. Okay, a curved thing will go like this. So this is the way that the electrode should get into the scala tympani of the basal turn. This is the importance of crista fenestra cochlearis. Now, suppose one has to do a cochlear implant electrode insertion via the round window membrane. We have to identify and delineate the round window membrane in its entirety. But if you have exposed full, but it is not ideal situation where the angulation is permitting you to go ahead into the scala tympani. In fact, in this case, if you insert an electrode like this in the number 1, it will go and hit the osseous spiral lamina and enter the scala vestibuli here. That is not desired. We want an insertion like this, like a 2 situation here. So whether the angulation is permitting your electrode entry like this or here is the one situation you have to identify by either your imaging or in an intraoperative situation. Rob Briggs from Australia in 2005 ACTA is also described by Thomas J. Balcony. He recommends a round window favorable angulation which would be less than 45 degree. If it is more than 45 degree, it is not a ideal situation where one can go ahead and do a round window electrode insertion. So a simple thing here, how to go ahead, whether you want to go ahead with a round window insertion or you want to resort to a cochleostomy, how to decide? After you do an adequate posterior tympanotomy and adequate drilling of the round window niche and exposing the round window membrane, the angle between the surgeon's site from the posterior tympanotomy with that of the round window membrane is nothing but round window membrane angulation. If that angle is less than 45 degrees, as in this case is 30 degrees, is an ideal situation where you can go ahead and do a round window membrane electrode insertion. If suppose the angle is more than 45 degrees, that is high up as 50 degrees in this case, that is not an ideal situation where one need to go and do a round window membrane electrode insertion. You can still do a round window membrane insertion, taking out this lateral most portion of the external artery canal, the inferior most region of the posterior tympanotomy side. You can sacrifice the chorda tympani. You can go with a anteriorly extended posterior tympani. You can do a round window membrane insertion, but it is not recommended if the round window membrane angulation is 45 degrees. It's better to do a atraumatic procedure than to do a traumatic recommended procedure. It's always you need to be as atraumatic as possible. Now, this is the same round window membrane, and this region is called as a hook region. A little say about the cochlea. I have a small video which was downloaded from the YouTube. Now, a small video clip here.
Very
Now,
deep in the petrous part of the temporal.
now, the cochlea is housed in the petrous temporal bone. The axis of the cochlea here, the central axis of the cochlea, is exactly perpendicular to the central axis of the skull. This is how exactly a labyrinth is located in the petrous part of the temporal bones. This is how the cochlea is there, and this is the spiral of the cochlea. We have nearly 2.5 to 3/4 turns. See, it is 2.5 to 2.75 turns. In reality, it is 2.67 turns. So this is the basal turn, this is the middle turn, and this is the apical turn. All these are divided by the interscalar septum here, and the individual turn is again divided into 3 portions. Here the scala tympani, superiorly the scala vestibuli, and in between will be the scala media or the cochlear duct. And this is the region of organ of Corti, which is a functional unit of hearing. And this is the osseous spiral lamina, which has been a cribriform like, where there is entry of the vascular channels and the nerve channels. The outer lateral wall is supplied by both arteries and venules, which are derived from the spiral artery or spiral modular artery and veins. The spiral modular artery is given by the internal auditory vein, which is a branch of anterior inferior cerebellar artery, which is in turn a branch of the basilar artery. The spiral veins, which again they are the tributaries of inferior cochlear vein, which drain into the sigmoid sinus via the inferior cochlear vein, which runs along the cochlear aqueduct. Okay, so this is how the organ of Corti is. This is the scala vestibuli, scala tympani, scala media. This is the lateralmost portion where there are the outer hair cells, and this is the inner hair cells here. There is a single row of inner hair cells, approximately 3000 to 3500 in number, and which are like a flask shape. These are the rows of outer hair cells which are arranged in 3 to 4 cells here, and they are nothing but like a cylindrical shape. These are nothing but the stereocilia, which are arranged in either a V-shaped or a W-shaped pattern, and these are like a dash like, okay, straight, more straighter. Here this is nothing but a gelatinous layer called as a tectorial membrane. The stereocilia of the outer hair cells reach the tectorial membrane, whereas the stereocilia of the inner hair cells do not reach the tectorial membrane. These are nothing but the supporting cells or the phalangeal cells, and these are nothing but the pillar cells which are housed in between the outer hair cells and the inner hair cells. This is called as tunnel of Corti. This tunnel of Corti again is filled with some fluid called as Corti lymph, which is similar to the perilymph. So the scala media is by filled with endolymph, whereas scala vestibuli and the scala tympani are by perilymph. The Corti lymph, which is there in the tunnel of the Corti, is similar to the perilymph. These are nothing but the nerve fibers which are innervating the outer hair cells. The nerve fibers which are innervating the outer hair cells go and run through the tunnel of Corti, but the nerve fibers which innervate the inner hair cells, which are more afferent in position, afferent in function, do not cross the tunnel of Corti here. So these inner hair cells, which are capable of transmitting the sound signal into the electrical signal through the auditory nerve, whereas the outer hair cells function is more efferent, and they actually modulate the function of the inner hair cells. Okay, so this cochlear spiral, if at all it is made as straight, that is called as cochlear duct length. So the cochlear duct length is approximately 25 to 35 millimeters. So it can vary once again. And the how to calculate a cochlear duct length is all given by Tardy's formula. That is nothing but CDL is cochlear duct length is equal to 4.1 or 4.0 into A. A is nothing but the linear distance or the distance measured from the lateral wall of the cochlea on either side going through the helicotrema as the linear length, and 4.1 A minus 3.98, that is given in millimeters. That's the same thing which is explained by Manu earlier. Now, a small note about the differentiation between the outer hair cells and inner hair cells and the perilymph and the endolymph. I'd just like to highlight only a few things here. So the outer hair cells, which actually their function is nothing but to modulate or pre-amplify the inner hair cells. Whereas the function of the inner hair cells is to carry on the signal from the interior of the cochlea or the hair cells towards the auditory nerve. This is called as transduction. Okay. And the second thing, the the protein expression which is called as prestin in the outer hair cells is the one which helps the outer hair cells to expand and again contract. So these outer hair cells can change its shape and size, but the inner hair cells are not. And a small thing here of clinical importance, when you have to know the function of outer hair cells, the outer acoustic emission or either cochlear microphonics will tell something about the function of the outer hair cells. In an inner hair cells, function can be once again can be identified by electrocochleography. So these are the differences between outer and inner hair cells, which one can note it down for the sake of postgraduate viva or theory. And the difference between the perilymph and endolymph, I think you all people know, but the one which are important are the perilymph is similar to extracellular fluid, which is rich in sodium content, whereas endolymph is similar to intracellular fluid and rich in potassium. Because of the presence of the potassium ions here, the electric potential of the endolymph is more, approximately 80 millivolts, and this is produced by stria vascularis, and the perilymph is nothing but an ultrafiltrate of plasma, or it can also be produced or thought to be produced by CSF. A word about the cochlear blood supply. This is a very complicated picture showing the blood supply. There's the arterial and the venous blood supply put together. We'll just divide it. So this is how it is. This is the arterial supply and this is the venous supply. The arterial supply, the main artery which is supplying the labyrinth is nothing but the internal auditory artery, which is a branch of anterior inferior cerebellar artery, which is in turn a branch of basilar artery. Once the internal auditory artery comes here, it divides into common cochlear and the anterior vestibular. The anterior vestibular artery supplies the ampulla of the superior semicircular canal and the lateral semicircular canal, the superior portion of the saccule and a portion of the utricles, and also a portion of posterior portion of the ampulla of posterior semicircular canal. Now, the common cochlear artery again divides into two branches, the posterior vestibular artery and the main cochlear artery. The main cochlear artery goes here and supplies the apical and middle turns and a portion of proximal portion of the basal turn of the cochlea. A branch from the cochleovestibular artery goes here and supplies the proximal portion of the basal turn of the cochlea. This is how the cochlear blood supply is. Now, we have to also emphasize on venous blood drainage. The main blood veins which drain the cochlear spiral is by the spiral veins. These spiral veins communicate and drain via the vein which goes along the or in the tunnel of the cochlear aqueduct. So there's also one vein which is most important is called as inferior cochlear vein, which is not shown here. The inferior cochlear vein also runs along a groove that is called as accessory canal, which is just similar to a cochlear aqueduct, which opens at the level of the round window membrane. If one has to do a cochleostomy or intervene the bony cochlea, the blood supply or the arterial supply or the venous supply may be hampered, which can lead to a few effects, which is going to reduce the performance of the cochlear implantation later on. So the venous drainage, or if it is impeded, or if the blood supply of the cochlea is compromised by any procedure on the bony cochlea, or a traumatic insertion, a very rude insertion or a very fast insertion displacing the cochlear fluid dynamics in the cochlea, can also cause some problem or cause insult in the cochlear blood supply, causing a reduced performance of cochlear implantation later on. Now, a small thing which is described in a pictorial way here. Now, we know that the cochlea has got 2.67 turns. So this is the basal turn, this is the middle turn, and this is the apical turn. The basal turn forms the promontory. This is the middle turn, and the apical turn is very, very small, which is just above the level of the processus cochleariformis. Below the level of the processus cochleariformis will be the middle turn of the cochlea. The three turns of the cochlea are divided by septum here. This is the cochlear partitions here. And the individual turn is again divided into three portions by the osseous spiral lamina in the medial most portion, and the basilar membrane will be in the lateral most portion. This divides into scala tympani inferiorly and scala vestibuli superiorly. Here there will be a tunnel of Corti, and there will be a resinous membrane, which will be a partition between the scala media and the scala vestibuli here. I could not show the resinous membrane and the scala media here in this anatomical dissection picture. Now, once you identify the the basal turn of the cochlea, you can differentiate between the scala tympani, the scala vestibuli. This is the osseous spiral lamina, which is towards the modulus, that is in more medially, and the lateral most portion is by the basilar membrane. This is the osseous spiral lamina, and this is the basilar membrane. This basilar membrane is the one which actually vibrates. Okay, that vibrations are carried over to the hair cells, that will be causing the stereocilia movement, that will cause the release of the neurotransmitter at the base of the hair cells, that will cause the firing of the auditory nerve. So the basilar membrane is very thin and more flexible in the basal turn. As it moves towards the apex, the basilar membrane will be more thick or more stiff. The vibrations will be very, very less. That is the reason why the vibrations in the basilar turn or basal turn is more responsible for a higher frequencies, whereas in the apical turn it will be towards the lower frequencies, and the middle turn will be the mid frequencies. The lateral wall of the cochlea has got some vasculature, if you can see here. Now, if you introduce a electrode like this, this will go like this. So you have to introduce into the scala tympani of the basal turn of the cochlea. Why? Because we are interested more in activating or stimulating the higher frequencies, which are responsible for the consonant recognition and word recognition, rather than going for a lower frequencies, which is usually well preserved in most of the cochleas. So the basal turn in the middle turn is to be stimulated more than the apical turn. So this is the electrode. This is the advanced bionics mid-scala electrode inserted through the round window into the scala tympani of the basal turn. You can see the interscalar septum, which is nothing but a bone here, which is the osseous spiral lamina, and this is the basilar membrane, and this is the scala vestibuli above, and this is scala tympani, in which the electrode has set in very properly. And this portion is nothing but the modulus, where the nerves auditory nerve fibers come from here. So the nerves go through the osseous spiral lamina like this and go towards the modulus, and from the modulus it will enter the cochlear nerve into the internal auditory canal and go towards the brain. Okay. Now the center portion of the cochlea is nothing but a bony portion which is called as modulus, where all the nerve fibers come and join here and go towards the cochlear nerve. So the higher frequencies are from the base like that, the mid frequencies are from the middle turn, and the lower frequencies are from the apical turn. The cochlear nerve is not a single nerve, it's a component of nerve fibers like this. So this is the complex of the nerve fibers here. The point at which the cochlear nerve enters the cochlea, enters the bony cochlea, the cochlear nerve enters the bony cochlea through a small aperture called as lamina cribrosa, or simply called as cochlear aperture. If the cochlear aperture is closed, is seen to be closed in a radiological imaging, that means the cochlear nerve is not in continuity. So you can't do a cochlear implantation and you can't elicit a response in the cochlear nerve by doing a cochlear implantation. So one has to see whether the lamina cribrosa is patent and good enough before going on and going ahead with a cochlear implantation. This brownish structure is not mud, though this is a dissected specimen. This is not mud, this is nothing but the neuroepithelium. This is the end auditory nerve fibers. This is how one can see at the auditory end auditory nerve fibers, and these join like that and go into the cochlear nerve here. So this lateral vasculature of the lateral wall of the cochlea on a fluorescence microendoscopic picture is seen here in a dissected picture like that. So these are nothing but the vasculature which supplies the lateral cochlear wall. We have shown the same blood vessels on the video which I have shown you. This has to be protected and they have to be respected if one has to go and drill onto the cochlea when doing a bony cochleostomy or a conventional cochleostomy. This is again repeating what I have said. This is the modulus here. This black thing is nothing but the end auditory nerve fibers or the neuroepithelium. This is the medial most portion between the scala vestibuli and the scala tympani. This is the osseous spiral lamina laterally, medially, and the basilar membrane laterally here. Okay, this is how a partition looks like. And the nerves, you can see this nerve is different from this nerve. This is the mid frequency nerve fibers and this is the high frequency nerve fibers. The apical frequencies are in the center. It is like in the center, it is like a whirl. Okay, the peripheral nerve fibers are nothing but the high frequency which come from the basal turn. The mid frequencies are from the middle turn, and the apical turn fibers are from the lower frequencies which occupy the center of the cochlear nerve. So that is what we have, and would be very happy to take any questions.
Thank you, Dr. Satya, for the presentation and very good tips. First of all, I would like to tell all the viewers that all the dissection pics in the presentation are not from some textbook or some hi-fi lab. Sir has done it himself during the fellowship period, and that too not with some high-tech equipment, with a normal microscope and pictures taken by aligning his phone with the microscope. So that is the importance of temporal bone dissection. Now, some questions, Satya.
Yeah, 1 minute. Just a minute.
Yeah. So that shows the importance of temporal bone dissection.
Yeah, I'm ready.
And that is the detail to which you can go in the dissection. So yeah, the questions now, first few questions from the initial slides.
Okay.
There was a question from Mr. Rajat Jain, Dr. Rajat Jain. He asked, in a subperiosteal pocket, do you secure it in any way? And is there any cases of migration? And if migration happens, how do you manage it?
Okay, that's a great question. The subperiosteal pocket, we don't keep any tie-down holes. Okay, number one. if the pocket is made very tight in between the suture lines, where the musculoperiosteal flap is very much tightly adhered to the suture line, there will not be any migration of the implant receiver stimulator. Number two, once coming about the migration part, if suppose one has manipulated the suture line and slipped off, though one has done that, in a growing skull, there would be always fibrous adhesions found between the soft tissues and also the implant receiver stimulator that would prevent the migration. If suppose there is a migration by any chance because of a hit or because of some reason, one has to go and always do a bed and secure it by a tie down holes. It's always a better way, but this subperiosteal technique is recommended for a an infantile implantee, or in a very young age group where the skull thickness is supposed to be less than 2 or 2.5 millimeters. Did I answer your question? Anybody over there?
Yes.
Can I?
Satya,
Yeah.
can you hear me?
Yes, please.
Yeah, so the next question is by Dr. Ajay.
Yeah.
There was a slide which you showed on study of mastoid pneumatization.
Study mastoid pneumatization. 1 minute.
12th slide.
This one?
Yeah, so they just wanted to know what are those two lines on the graph. Is it some comparison of age or what is it?
No, actually. These are, a very good observation, Dr. Ajay. I congratulate that for you. See, these are from two different populations.
Okay.
This is one from the Indian subcontinent. The other, I suppose this is from Europe. I don't remember, but one is from an Indian subcontinent, one is from the European population.
Okay. Next question was.
Various groups.
Next question was, can you just describe about the stalactite term which you used in the mastoid?
Yes. See, the stalactites are nothing but a cribriform area-like thing. These are nothing but a honeycomb appearance like of the mastoid antral system. Okay, these it will be like honeycomb-like appearance. These are small partitions which separate the small air cells. That once you open the stalactites, then that can lead to a bigger air cells, nothing but the mastoid antral air cells. This is nothing but a small partitions like thing in between the air cell system of the mastoid.
Yeah, that word is basically derived from those limestone caves where projections form from the roof. So that is called stalactites.
Yeah.
Okay, next question is Mr. Hafsa Ansari just wanted to know about varia technique related to this anatomy.
Yeah, great. Now, I'll show a better picture here. Yeah. So the varia technique is derived from a place named as Varia in Italy. This is described by Professor Kiran. So what is that? The electrode insertion is into the scalar tympan of the basal turn. There is no doubt about that. There is the same thing. Now, how do you enter the scalar tympani of the basal turn? Is by either a round window or cochleostomy. So in a case of varia technique, you go and open the cochlea by drilling the cochlear lateral wall, that is bony cochleostomy, and enter the scalar tympan of the basal turn. That is the same. Now, how to enter the middle ear is different. In a case of standard mastoidectomy posterior tympanotomy route, we go by this route. In a case of varia technique, instead of opening the entire mastoid, we do a suprameatal well. Supra means above, meatus means exonotor meatus. Suprameatal well here. From that area, you enter the middle ear by drilling a small tunnel-like thing parallel to the posterior superior portion of the bony external auditory canal after elevating the tympanomeatal flap. So you take a endoral incision and then expose the middle ear by elevating the tympanomeatal flap. Then you expose the mastoid cortex. Don't do the mastoidectomy. You do a suprameatal well. And there is something called as Triffon's perforator, which has got a drill and a guard. The guard is kept in the external artery canal. The drill is in the posterior superior portion of the external artery canal. You drill through the external artery canal like that, parallel to the external artery canal, and enter the middle ear via again the facial recess. You are going to enter the facial recess once again, even in a case of Varia technique. Where to start, where to end? Superiorly or laterally, the start of the drilling is at the 11 o'clock position, and you enter the middle ear through the facial recess at the 10 o'clock position. You are always going to guard the drill system by keeping the guard in the external artery canal. You drill exactly parallelly and posterior superiorly to the bony external artery canal. You enter from the mastoid cortex here and go into the middle ear via the facial recess. And you are always drilling lateral to the incus. So once you go medial to the incus, you are going to hit the facial nerve. If you are lateral to the incus, you will not have any problem.
I
So
think
that is
Dr. Manusruti will be speaking more about this on tomorrow's lecture, I think.
yeah.
Yeah, the surgeries and techniques we'll discuss tomorrow.
Yeah, this technique is mostly followed by Dr. Kirtane, sir, I think. Is it?
Who?
No.
No.
Kirtane follows posterior tympanotomy. And it's Dr. Hans.
See, once again, let me remind you, there are lot many techniques. There is standard mastoidectomy, posterior tympanotomy, or facial recess approach. This is the FDA approved technique. There are lot many techniques like Varia technique, suprameatal technique, or transcolored technique, or a middle turn cochleostomy by a middle cranial fossa approach. But only recommended is standard mastoidectomy, posterior tympanotomy. Though we are advocates of standard mastoidectomy, posterior tympanotomy, there may be a situation where you need to resort to other. So you know all the techniques, but do the best in your hands, and which is required to given situation.
A couple of questions on facial recess. One question was, what is the width of the incus bridge, and how wide do you keep it?
Yeah, exactly. See, ideally the incus buttress should be as thin as possible, but don't take it out. It may be left out to approximately 1 millimeter.
Another question is regarding the sentinel cell.
Yes.
How to locate it and what is the location?
First, sentinel cell, whether the facial recess has got any pneumatization or not, can be seen prior to surgery or dissection, prior to surgery in a imaging, first thing, number one. Whether the facial recess has been adequate or not, if there are any cells, can be identified on the pre-op imaging, number one. See, you don't depend upon the cell to open it. You depend upon the anatomy and your surgical skills or expertise to go ahead and do a posterior tympanotomy. It is not always the sentinel cell which will lead you. Okay, it's always the anatomy.
Couple of questions on the crista fenestra.
Okay.
One question was, is crista fenestra, is the crista visible on preoperative radiology on the CT?
Yes.
Yes,
The
it can
crista
be made out, especially. Yeah, go ahead.
Yeah, crista fenestra is visualized on imaging. How to locate it? A simple thing is first you see the coronal section. So if you have a cochlear spiral like that, the round window membrane area, if it is a small hitch-like thing like that, then that is a prominent crista. You just follow the round window membrane inferiorly. In a case of a coronal section where you see a cochlear spiral, that will indicate whether the crista is prominent or not.
Okay, next question was, do we drill the crista while doing a cochleostomy?
See, while doing a cochleostomy. Is that while doing a
That's the
cochleostomy?
question. Yeah, while doing a standard cochleostomy, do you drill the crista?
Crista is drilled not drilled in a case of round window approach. It is drilled in a case of extended round window. It is escaped in cochleostomy. You understand?
I think that was clear. Next, there was another question. What is the outcome if the electrode goes into the scala vestibuli? And how does it affect it? Yeah.
Okay. Simple thing. See, if suppose it goes into the scala vestibuli accidentally during the procedure of cochlear implantation at the first sitting, you will not be getting a reasonably good response on intraoperative electrocochleography. Okay, intraoperative electrophysiological testing will not give a good picture. If suppose even there is a response, the currents will be very high, and you can also detect it by seeing high impedances or high currents on ECAP measurements, and you can also identify it in case you go for a imaging by CT scan, not by a X-ray. If suppose you do a post-operative X-ray on day 1, you may see a kink of the electrode after it has entered the cochlea. So that might give you one clue that it has entered the scala vestibuli. And one more thing to add, as you go from the base towards the apex, the dimension of the scala tympani will reduce, the dimension of the scala vestibuli will increase. So invariably, if you are inserting a longer electrode, then that electrode will invariably enter into the scala vestibuli towards the apex.
Yeah, just to add on that, and if it goes into the scala vestibuli, you may need higher currents for stimulation.
Exactly.
And long-term results may not be that good. And also there may be problems during revision implantation, because when you're pulling that electrode, which has gone through the basilar membrane, you can imagine how much damage it can do when you're doing a removal and reinsertion with a fresh electrode.
Yes.
Last question. There are a couple of questions on the round window angulation. So if you can just summarize it, how do you assess the round window angulation on table?
Okay, got it.
Thank you.
Where did I go? Just give me a second. So I need to show you two slides. So the round window angulation is given by the angle between the site or the site of vision of the surgeon through the posterior tympanotomy and the round window membrane. Suppose the vision of the surgeon is through like this, and the plane of the round window membrane is like the angle formed between the surgeon's vision or sight through the posterior tympanotomy and the angle between the angle formed by the line drawn along the axis of the round window membrane. That angle will give you the round window angle, visualization angle. If suppose it is less, then it is more favorable. If it is high, then it is favorable towards the cochleostomy. So this, if you suppose see this one is more flatter, so that means it is above the 45-degree angulation. So you can't insert an electrode like this. Instead, you will be inserting an electrode like this. So this is not a favorable situation. Here you are seeing the face of the round window membrane in its entirety. So that means this is at a very good angle where you can insert an electrode through this. If you see the round window membrane here, but it appears to be very small as compared to this. That means the round window membrane, though of a same size, if it is tilted to more extent, more than 45 degrees, the round window membrane is going to be seen very small. It's not going to be seen a better way. It will be illusion like thing, where you will be seeing a round window membrane which appears to be short. And if you keep supposedly keep a 1 millimeter diamond bar, you will not be able to cover the entire situation there. So that will be a situation where the angulation is more. You can't go and measure it, but it is just a assumption that this is more angulated or less angulated. So if it is less than 45 degree, go for a round window insertion. If it is more than 45 degree, resort to conventional cochleostomy or extended round window, or else you can go with a round window membrane. It's not that you can't do it. You can do it at the expense of extending the posterior tympanotomy or doing something like a Brackmann's technique.
Okay, next question. Before that, there's a request if you could display the slide with facial nerve landmarks.
Great, great. Hold on.
Yeah, 15. Yeah.
Okay.
And now another question. What is the, why do you place the electrode in the scala tympani? Is a question.
It's a good question and a basic question. Okay. Yeah. See, once you imagine the cross section of the cochlea, we have three things: scala tympani, which is inferior, scala vestibuli, which is superior, and scala media, which is the medial portion. The auditory nerve fibers are very close in the osseous spiral lamina, which is nearer to the scala tympani. So if you go and insert the electrode in the scala vestibuli, that means the electrode has to give more current so that the current from the electrode is received by the end auditory nerve fibers at a far distance. If you have to stimulate the auditory nerve fibers with the less current, you have to place the electrode and give the current very near to the end auditory nerve fibers. So of all the three situations, scala vestibuli, media, and the scala tympani, the auditory nerve fibers are close to scala tympani. So we are going to introduce the electrode in the scala tympani so that it will be nearer to the end auditory nerve fibers. If suppose you keep in the scala media, which is very, very, very small, you are going to disrupt everything, and there will be a communication of the perilymph and the endolymph, and there will be a mix-up of the cochlear fluids, which is not at all good. So the ideal situation is a scala tympani. Yeah, you can go for a scala vestibuli in a situation where you can't go with a scala tympani insertion, like in a case of scala tympani ossification or labyrinthitis ossification or cochlear ossification.
There are a couple of questions on cochleostomy site.
Yeah.
What is the site of cochleostomy? Anterior, inferior, posterior.
Yeah.
Where is the crista fenestra? And how do you do the extended cochleostomy?
Okay, great. So there are three questions, right? The site of cochleostomy.
Yeah, the site of cochleostomy. How do you drill the crista fenestra? And the types of cochleostomy.
Types of cochleostomy. Okay. The site of the cochleostomy varies as per the size of the cochlea. Okay. That is called as adaptive cochleostomy. See, we have different sizes of cochlea. So if there is a bigger cochlea, you'll have more space. If you have a smaller cochlea, you have a lesser space. The dimensions of the cochlea in width is approximately 8 to 9 millimeters, and the height would be somewhere around 7 millimeters. If you have a very wide cochlea or a bigger cochlea, then you will be having more space to go ahead with a adaptive cochleostomy or a conventional cochleostomy. In any given situation, first and foremost thing is you identify the round window membrane. After identifying the round window membrane, go 1 to 1.25 millimeters inferior to the round window membrane inferior margin and a little bit anterior. So inferior and anterior approximately 1 to 1.25 millimeters below the round window membrane is the site for conventional cochleostomy. That is the first question answer. The second thing, how do you drill crista? See, the crista is drilled in a case of extended round window membrane. So what you do is you open the round window membrane. You open the round window membrane in this way. I'll just show you. So if suppose this is the round window, this is the inferior portion, this is the superior portion, this is the anterior portion, this is the inferior portion. You expose the round window membrane like that. Open it like this. Am I okay? So you take out the inferior and anterior most portion and like this, and you drill here, anterior inferiorly. So if you drill anterior inferior margin of the round window membrane, that is called as extended round window insertion or extended round window technique. Now, what was the third question? The types of cochleostomy. So basically there are 3 routes to enter cochlea. You can also classify as a 2 routes. One is via the round window, that is called as a round window technique. The other one is cochleostomy technique. Cochleostomy means opening of the bony cochlea. You drill along the round window membrane, it's called as extended round window. You do a separate bone cochleostomy. That means you drill the lateral wall of the cochlea without touching the round window membrane, a little bit inferior and anterior. That is called as a conventional cochleostomy. So both extended round window and bony conventional cochleostomy come under cochleostomy, and round window is without cochleostomy. That means you don't drill the bone. The disadvantages of cochleostomy are 3 here. Number 1 is mechanical trauma. When you drill the bone, there will be mechanical trauma. Number 2 is thermal trauma. That means it generates heat. The third one is vascularity.
Last question,
Yes.
and then I think we'll wrap up the session.
Yes.
The last question is if you can repeat the Brackmann technique.
Brackmann technique. Okay. Yeah, this is the one. So Brackmann's technique or a Bruce Gans technique modified is the extension of the posterior tympanotomy anteriorly. That means anteriorly extended posterior tympanotomy. How do you do that? You do a posterior tympanotomy as described. You extend the posterior tympanotomy superiorly by taking out the incus buttress, inferiorly by sacrificing the chorda tympani. That means you are extending superiorly and inferiorly. Now, to extend anteriorly, you give a vertical cuts in the posterior bony canal wall superiorly at the level of the bridge here, like this. Here, that means lateral to the editor side antrum, and a vertical cut in the inferior portion at the chorda tympani level here, at the inferior portion of the posterior tympanotomy side. So you give a superior and inferior vertical cuts over the posterior bony canal wall without damaging the external auditory canal skin. The canal skin should not be touched. It should be left intact. So once you make only bony cuts, you push the bony canal wall. It will go. It will not open into the external auditory canal, but it will yield. So you open it by pushing the bony canal wall. You gain access to the middle ear here. Once you do the procedure, again keep this back like that, so that the external auditory canal is not opened. Why? Because the canal skin is intact. You can again seal this vertical cuts either by a bone wax, or you can use a bone paste mixed in antibiotic steroid.
Thank you. There are a couple of questions coming on ossification and all. I would like to remind the viewers that we have another talk tomorrow by me about the surgical technique, and then we have future talks on complex cases like ossification and other anomalies.
Yeah.
So I would thank you all. Thanks, Satya, for the good talk. A lot of
Thanks, Satya.
congratulatory messages for you. And
Thank
people
you.
are
Nice
requesting
comment,
for it to be posted on YouTube. I think we'll be doing it at a later date. All the videos would be available for viewing.
Yeah.
Thank you all.
Any
Thank you to
questions
all.
can be posted to Harsha. We can answer them later on also. Even if you have any questions which cannot be asked in this session, can be still answered by just posting it to Harsha. Harsha will forward the questions to me,
please.
and we'll be able to answer it.
We can take questions in all our social media handles.
Yes.
If you can post it there, so I can send it to sir's WhatsApp or any other. Okay,
Yeah.
thank you, sir. Once again,
Thank you.
we've completed third edition now today. We'll see you again same time tomorrow. And
Yeah.
tomorrow's speaker would be Dr. Mastoid. He'll be speaking on surgical steps of cochlear implantation. And timing is the same, 4 to 6 p.m. Okay.
Yeah. Thanks, Manu. Thanks, Harsha. Thanks,
Yeah.
everyone.
Thank you all.
Right.